Hey everybody, let me know if you can hear me in the chat. Perfect. Good, so I'll assume everyone can hear me then. Looks like we got 20 people in so far. I'm going to get started in just a few minutes here, but I figured I'd at least test everything out, make sure it's working. This will be recorded for later viewing, so don't worry if you miss anything. You can always go back. Or the nice thing about YouTube is you can pause me, go to the bathroom, and come back. That's totally fine too. In the meantime, if you have any questions or anything, you can certainly post them up in the chat. I had 30 people, now I'm down to 18, so I guess I must have scared everyone off already, so it's unfortunate, but it is what it is. But yes, this is pretty fancy. I've been doing this, I got to practice last semester when we went distant, so I think I'm getting okay at the YouTube thing. So, but this has been my platform for a while. I always record my lectures, so this just gives me an opportunity to do it live, and I think it sounds better than the Zoom lectures. You don't have to hear me all kind of low bit rate. You can hear me just kind of as I sound. And I'm sorry you're perpetually scared. That's no good. That's okay. We'll get through it together. I will be that somewhat calming voice, I hope, that says, hey, it's all going to be fine. So I got kicked out to make a YouTube channel to comment, but I'm back. Maybe that's what happened to rest. Perhaps. That is possible. Good. I'm glad the quality's better. Hey, Allison. Yeah, we're up to 29. That's pretty good. I don't expect everyone to show up. You know, I want to give people the option, you know, kind of come back and watch it later if they like. So, hello, Rachel. I mean, I know all of my advisees are surely going to show up because, you know, they know what the consequences are otherwise. Just kidding. There are no consequences either way. Oh, you don't even know that yet, because I might be the worst one, and you just have no reference points. So just wait. It's hello, everyone. Thank you for joining. 37 is pretty good. Yes, well, I'll speak a lot of things into existence, as you'll see. Let's hope they're all true. Give it a minute or so. That's pretty good. About 2/3 of the class almost, so I'll take that for sure. You might see me kind of looking off to the side a bunch just because I'm trying to look at the chat while I'm doing this. That's kind of my only way to see if you guys are responding to anything or not. It's kind of like me staring at you, but I don't have the crowd. Otherwise, I'm just talking to myself for like 2 hours, and that's just a little odd. But it's almost 12:30. I'm going to go ahead and hit the record button. So, hello, everyone. My name is Dr. Wood. If you don't know me yet, I feel like you've all been in school for like 2 years already. I'm just now getting into the game, but it's the nature of the schedule. Welcome to your Pharmacodynamics course. So this is how I'm going to do my courses. I will have all of my lectures live on YouTube. Again, they'll be pre-recorded. Yeah, probably does feel like 2 years, Richard. It will be recorded, posted up later on, so you can always go back. I do it on YouTube as opposed to Zoom. Even though I can't see you guys and maybe have that particular interaction, it allows me to, one, have better voice quality, I think, so you can hear things a little bit better on your end. You guys don't normally like to participate in terms of like having your cameras on and talking anyway, which I don't want to force anyone to do that, so that's fine. But yeah, so I do still want it to be interactive, so I still want you to post up questions in the chat. There is one other thing, one other way I use to try to encourage people to ask questions, because oftentimes people are a little apprehensive about doing so. So if you go to the course homepage, and I'll kind of walk you through the website real quick, you can see basically the schedule, how to get to all of the live streams and whatnot. Just note that the last one is going to be on Zoom, because that's going to be our review session, and that one I'd prefer to not have like a delay. We can kind of talk back and forth a little bit more. So that'll be on July 31st. You also see the assignments are going to be due in about a month or so. Don't worry too much about those. I'll talk about those in just a little bit. But getting into where the modules are, you can see our syllabus here. And then where I want to mention how you can interact more. If you would like to do it in a more anonymous sort of way, there's this Pharmacodynamics sticky board you can click on. And basically this is a way to like post anonymous sticky notes. And so you can ask any questions there. Will check it maybe once or twice during class, and then answer those questions there. And so the benefit is everyone kind of gets to hear it instead of just one person like emailing me a question. You can certainly feel free to do so anyway, so don't worry about emailing me in the off time, whatever. The benefit though is if everyone can see the question, then everyone gets the benefit of the answer there. So feel free to post there or in the chat, and I'll try to respond to that as best I can. Getting back into the syllabus real briefly, I think I have that up somewhere. I just want to walk through how the course is graded. So basically you'll find that we have, let me see, we're going to have 3 assignments. There's going to be a prescription writing assignment that will be towards the end of the class. It'll be about 10% of your grade. And then we're going to have a dosage calculations assignment where it's set up as a quiz that you can kind of take over and over. Don't worry about that right now. We'll get to it in a little bit later on in the course. There'll be a drug information assignment. All of you will have been assigned a drug, and you're going to have to answer some questions about that. Again, we'll wait a few lectures before we really get into the meat of that, because right now you don't really have any context for that stuff. And then we just have one exam at the end that'll be worth 80%. So we included the assignments because, one, it helps to enhance your learning a little bit, but it also helps to pad out the grade. Not pad out the grade, it's a bad way to say it, but it helps to lessen the weight of the exam. We used to only just have, when I first started this, just the one exam, and that was your only grade in the class, and it was kind of like make or break, and everyone was like super anxious, and there's a lot of tears and all that. No good. So I said, let's bring in some more assignments, right? So you'll have all those there. You can see the due dates as well. So we'll get into talking about those more a little bit later on. Let me see here. So anyway, so that's that about the course for the most part. Yeah, and so basically, and some people with my PowerPoints, they don't like the dark blue with the white text. I prefer dark mode for a lot of my apps, so this is how I like to set my stuff up. If you don't like it, you have the PowerPoints, you can change it to whatever you want, so feel free to change the colors however you like. But basically, this is your Pharmacodynamics class. This is going to be setting up basically everything we do in Pharm 1 and Pharm 2. This will be a very different class than those because we're not going to get super in-depth on all of the medications that we're going to be using for different disease states. Kind of like how you're not learning a lot of pathophys yet. You got to learn all the basics first, right? So you have to go through your anatomy and physiology, and then we can get into all the disease states next semester. So we're trying to lay the groundwork here. And then there's only 1 credit hour, 16 hours of instruction, so we'll meet 8 times, including today. That one exam at the end, and then those assignments, as I mentioned. And of course, you have to make a 75% or greater to pass the class. So I don't foresee that being too big of an issue. To be fair, this class is probably much easier in terms of like the test material than you're going to see with a lot of the stuff in Pharm 1 and Pharm 2. Right? I'm sure many of you have probably heard that I have a reputation about my courses being pretty hard. This is not really that. That'll come next semester. So without further ado, I wanted to get into talking about some definitions, right? Because we got to know what our definitions are to know what the lingo is to be able to even discuss some more of the concepts in more depth here. One other thing to note, with the YouTube live streams, you can pause me, go to the bathroom, get a drink, whatever you need to do, and come right back. Some students like that benefit. I'm not going to break for 10 minutes in between. I'm just going to go for the hour 40 and let you guys go probably was it 210, something like that. So that way, it's going to be awkward if I leave for like 10 minutes and it doesn't really work out like we would in person. So, so feel free if you need to pause me, take a break. No issues with that. So anyway, getting into our definitions. First off, drug names, right? So I'm sure most of you are familiar with some few drugs that are out there, especially some OTC drugs. When we talk about drugs, we basically have our trade name, which is like the brand name of the drug, and this is like exclusively used by just one company. So if you hear like Motrin or Advil, that would be a trade name. There's a generic name that every drug has, which I encourage you all to know sort of at a baseline. So for instance, with Motrin, the generic name would be ibuprofen. That's what the FDA or the Food and Drug Administration actually approved its name as. Everything else is just marketing, really. So when you are out there clinically and you're seeing medications, you may see things or people refer to drugs as their brand name. Like I'm sure many people who've had some experience have heard of the drug Lasix. Lasix is a diuretic. It's a water pill. You might not have heard of furosemide, but furosemide is the generic. Lasix is the brand name. I encourage all of you to know, at the very least, the generic names, because that's kind of the common denominator. Everyone should know what you're talking about when you say the generics. But again, for instance, it's easier to say Lasix than furosemide, so most people just call it Lasix, right? So when I do my tests and I have drug names on a test, I'm always going to have the generic and the brand name. And I do that to make sure that you're starting to get sort of those connections being made, so that when you see one, you can sort of translate it into the other when you see it out there in the real world. I believe the PANCE is only going to have generics, though. So at a baseline, you should probably know your generic names when we get to those next semester. So those are the names. Getting into further classification. So then you get into what we call a pharmacotherapeutic classification. And so for this one, it falls under the non-steroidal anti-inflammatory drugs, or NSAIDs. So this is sort of an umbrella term that many drugs can fit underneath. So for instance, if you've heard the drug Aleve or naproxen, naproxen being the generic name, that's also considered a non-steroidal anti-inflammatory drug. Frequently, you're going to find that a lot of these classifications, they tell you right in the name what the drug does. So with here, non-steroidal, it's not a steroid, it's an anti-inflammatory drug. Pretty straightforward. That may not always be quite so apparent. So for instance, when you hear like the HMG-CoA reductase inhibitors, whoa, like that doesn't really tell you that it's used for hyperlipidemia. Okay, we'll learn that stuff though. We'll learn what those drug classifications actually mean. And then we'll get into the mechanism of action, the MOA for the drugs. This is specifically what they do in the body to cause their desired effect. So in this case here, it inhibits the enzyme cyclooxygenase, and that decreases prostaglandin synthesis, and that decreases inflammatory production of inflammatory mediators. You decrease inflammation, right? And then you get into the indications. Actually, what do we use it for? So in this case here, we use it as an anti-inflammatory. We use it as an analgesic, so we use it for pain, and it's an antipyretic to get fever down. So you could use it if you have a cold or if you have the flu or whatever the case may be. Use it to get your temperature down. Those are different indications. Now, note, a lot of drugs will have what they call FDA-approved indications, and that's specifically what the manufacturers went and actually got approval for. And we'll talk about that approval process later on. You may hear of off-label uses, and so that's when you're using the drug for things that maybe the FDA did not approve it for. That's not like illegal or anything. Usually you need to have some sort of like evidence behind you to say why you're using it. But those off-label uses can sometimes be the most common reason why you would end up using a drug for that particular purpose in some cases. So sometimes you'll find the approved use is a minority of its use for a particular drug. So when we talk about pharmacology, what is pharmacology? Yeah, kind of like the COVID treatments. In terms of that, so like that's undergoing the some drug like remdesivir is an antiviral to going through the approval process for COVID specifically, but like hydroxychloroquine, that's an off-label use, which now we actually find out that is not really all that effective at all. It's a very good point, John. So getting into pharmacology, that's really the study of the reactions of drug in the body. So not only that, but also looking at like interactions between other drugs that are also in the body at the same time. And so pharmacology can be broken down into two further terms where we get pharmacodynamics and then pharmacokinetics. And so we'll talk about what those two terms mean here right now. Pharmacodynamics is basically looking at like what the drug is doing to the body. So you're looking at the mechanism of action of the drug, you're looking at the relationship between how much drug there is in the body and what sort of effect you're getting. You're looking at the therapeutic effects, you're looking at the toxic effects, everything that the drug is doing to that body. That's what you're looking at. And so again, the drug affecting the body is what we're seeing here. When you say, this drug causes you to urinate, it's a diuretic, that's the pharmacodynamics of the drug, all the way up into it leading to dehydration. That's part of the pharmacodynamics as well, both useful effects and toxic effects additionally. I like to use ethanol for a lot of my examples, as you'll see, basically because it's probably something that most people have either been exposed to themselves or perhaps they have seen other people being exposed to it. So everyone pretty much has a good idea of what ethanol does. So don't let this being a common example that I use, don't let that be any sort of reflection on me. Although some people say I put the fun in barely functional alcoholic, whatever. I'm just kidding. Don't take everything I say as the holy gospel, right? Anyway, getting into ethanol, looking at your different doses here. So you can see that there's a relationship between the dose of alcohol someone gets and the actual effects you're going to see. So low dose, say you have like 1 to 2 drinks, you sort of have that loss of inhibitions, you sort of get that social lubricant sort of effect. Maybe you're going to be more likely to talk to that person who you think is cute, things like that. Well, what if you go to moderate dose? You start to get up to 3 or 4 drinks. Now you're starting to slur your speech a little bit, you're getting coordinated, trying to walk over to that person, and you trip and fall, right? Higher doses even than that, now we're starting to get depression in our mental status, we're starting to get respiratory depression, you may vomit and aspirate. So you can see there's a clear linear effect between that. You have 1 drink, you get an effect. If you have 10 drinks, you're on the floor, right? So it's a pretty clear thing. And you can see that with many, many drugs, as we'll see going forward. So again, the effects of the drug on the body. Getting into the kinetics of it, now we're looking at what the body is doing to the drug. And so we're looking at the relationship between concentration versus time, because really any drug in the body doesn't stick around forever. At some point it's going to get eliminated. And so how the drug gets absorbed into the body, how it distributes throughout the body, and then how we metabolize it and excrete it is all part of the kinetics. So whereas pharmacodynamics is what the drug does to the body, this is what the body does to the drug. Okay, so specifically we're talking about things like how it gets absorbed from the GI tract and what the liver does and how drugs get distributed to the fat tissue and all those things. That's what we're talking about here. To go back to ethanol as our example here, we can see that the kinetics can actually change pretty greatly depending on the type of patient you're dealing with, right? So for instance, if you have someone who's alcohol naive, they metabolize alcohol at roughly a rate of 20 milligrams per deciliter per hour, right? That's roughly a drink per hour. However, though, you can see changes in people as they are chronically being exposed to ethanol. You can see that they actually upregulate enzymes in the liver to make them more efficient at metabolizing it, because ethanol itself is a poison that the body wants to get rid of, right? So you can find they may be able to metabolize 3 to 4 times more per hour than someone who has no real exposure to alcohol on a regular basis, right? Those are the kinetics. Those are the things that change, and we know that. So if I see someone who comes in who has a history of being a chronic alcoholic, I know that they're going to be metabolizing and processing that drug much differently than someone who, say, a college student who just went off for their first year freshman party and then had way too much to drink. They're going to process it much differently, and so those are things you'll kind of pick up on as we look at how these drugs work in the body itself. So when you're looking at sort of the breakdown, you can see here, let's say we give a dose of a drug, from there it has to be absorbed. We're going to find that we'll have our drug get absorbed into that systemic circulation. When I say that, I'm really talking about like the bloodstream, right? So how it's circulating throughout the body, and then how it gets distributed and eliminated, that's our pharmacokinetics, right? That's basically what the body is doing, how it's processing that drug there. Once we get the drug circulating around and it actually gets to its site of action, whether it be in the brain, whether it's the heart, wherever the case may be, that's where we see our pharmacologic effect. And that could either be clinical response in terms of efficacy, or we could see our toxicity here. And this is the pharmacodynamics, and we'll talk about that. So when I talk about things like a blood pressure medication, how it lowers your blood pressure, that's a pharmacodynamics. When I talk about drug interactions that lead it to be metabolized more slowly, that's a pharmacokinetic sort of thing. So I kind of have an idea of what we're talking about when we get into the specifics later on. There's a term called pharmacogenomics. And as you might imagine, this is going to be that interplay between genetics, the person's genetics, and how this is going to have an effect on both the pharmacodynamics and the kinetics of a particular drug. And so this is a relatively new field in the grand scheme of things, but as we move forward and we find more of these sort of relevant tests that we can do and they become cheaper and easier, this makes it much more likely to play a role when you're making clinical decisions about how to dose a medication or whether a medication is even a good fit for a certain patient. For instance, there's a certain drug that we use for HIV, and basically if a patient has one polymorphism, one specific one we can test for, they're very likely to have an anaphylactic reaction to it. So you got to test all those patients to make sure they don't have that, and if they don't, then you can use the drug safely. Otherwise, you got to skip it completely, right? There are many more examples of that, but this is just one. So when we're talking about drugs, you want to think about this in terms of a lock and key sort of analogy here. So the drug is going to be the key. It's going to have a particular shape, and it's going to be able to interact with different tissues and different targets within the body itself. When we talk about what the key is interacting with, what that lock is, that's where we talk about receptors, right? And we're going to find there's a lot of different things that can be receptors for these drugs here, but it's basically any component of the cell or an organism that's going to be interacting with that particular drug, okay? The receptor may be on the cell surface, it may be located within the cell, it could even be parts of the DNA potentially we're dealing with. Most of the time it's going to be some sort of protein that the drug is going to be interacting with. So for instance, it can affect certain transporters, or it can affect an enzyme in particular. It could even be DNA targets, right? So for instance, if you have a patient with cancer and their cells are replicating with no checks and balances on it, that keeps replicating, you can target the DNA and damage the DNA to kill the cells off, right? So anything could be a potential receptor for a given drug. And you're going to see that based off the interaction between the drug and the organism, you may find that the body will try to adapt to that, and you can see different regulatory things that can change in order to adapt to that. Because one of the things I'll kind of key in on with this is that the body likes homeostasis. It likes being at its baseline state. The baseline state can change with disease states and things like that, but the body resists change. And so, for instance, you can find by applying a drug, you may find you have up or down regulation of certain components. Just like I mentioned with the ethanol example, you give ethanol to someone chronically, they upregulate hepatic enzymes to metabolize it more efficiently to get rid of it. So things like that will be some changes that we'll look at in the upcoming lectures. And so we can kind of think about it in terms of almost like a chemical reaction, right? You have a given amount of drug here, and then the receptor, and depending on how much drug is available and how many receptors are available, this will tell us, okay, well, what's the likelihood of these two meeting up and causing this receptor-drug complex forming to lead to whatever downstream effect. And we'll get into all of that a little bit later on. And we'll see that by changing either the concentration of the drug available or by changing how many receptors are available, this can either make this less likely to happen, or you can drive that reaction over to the right here, make it more likely to occur if you have more drug or more receptors available, right? So we'll get into more of that in that regulatory role in just a moment. When I say the term ligand, that's basically any molecule that normally would bind to a receptor and is pretty key to helping with chemical signaling within the body. We'll talk about like natural endogenous ligands, which are things that your body already produces to interact with various receptors in the body. So for instance, when you have, you're about to take your test in the morning or something, and you're releasing all that norepinephrine and epinephrine from your adrenal gland, your sympathetic nervous system, those are neurotransmitters that are then interacting with various receptors throughout the body. That's why your heart rate goes up, because your epinephrine's interacting with beta receptors in the heart, right? So you start sweating and things like that. This could be really anything. It could be hormones like insulin or cortisol. I'm sure most of you have a lot of cortisol flowing through you right now. It could be drugs like acetaminophen and various other ones. It could be even antibodies and things like that. Really anything that interacts with the receptor can be a ligand. When we say hormone, this is basically a natural substance that's produced within the body that can influence essentially how the body's growing or developing, as the case may be. It's kind of like the body's own drugs that it's producing. So for instance, if you're in a state where you are trying to grow muscle, maybe you'll release more testosterone. Or if it's in a state where you're chronically stressed, like you have exams all the time and you have to, sit and listen to me for 2 hours. Maybe you're producing a lot of cortisol or insulin when your blood glucose goes up. Whatever the case may be, these are kind of like endogenous drugs. In some ways, we can actually replace those with exogenous versions as well. I can give you transdermal testosterone. I can inject you with insulin, things like that. Not me personally, I would never do that to you, but people could do that. And then we talk about xenobiotics. That's basically any sort of chemical compound that is foreign to that living organism. So if I were to give someone acetaminophen, that's considered to be a xenobiotic, really anything that a person would not normally be producing themselves. I like these a lot, mainly because it's my clinical background, which I suppose I should have talked more about. I apologize. I'm still not used to doing these classes and starting them off online. But my background, and if you didn't know, I'm a pharmacist, right? But my specialty is in emergency medicine and clinical toxicology. So I do a lot of things with like drug overdoses and snake bites and all of that. And that study of poisons within the body is toxicology. And so I'm a clinical toxicologist as well. I actually still you take call for the poison center like 3 times a month overnight and things like that. But basically, there's 2 kind of main things that fall under toxicology. There's toxins. That's actually like natural things of biologic origin that could be potentially poisonous to the body. So for instance, if you were to be bitten by a poisonous snake in Florida, which for those of you not naturally from Florida, yes, we do have many poisonous snakes, but fortunately, social distancing regulations have been in play for snakes for a long time. I think just natural fear, but people still get bit all the time, and those are considered to be toxins. Botulinum toxin is considered a toxin, right? Even though we use that for aesthetic purposes, or we use it for, actually there's a lot of things with certain muscle spasticities we'll use that for too, but that's a very potent poison, in fact. And so we study the toxic effects that come about from that, right? A toxicant is really anything that comes from a more non-biologic origin. So if you consider like pharmaceuticals, lead, if you had someone who had a Tylenol overdose, that would be considered a toxicant because it is something that is synthesized, it's non-biologic in nature. Like I said, toxicology is just a study of all that stuff. So I did a 2-year fellowship with the poison centers and actually got to, run an inpatient sort of call service that we did in the hospital I studied at, and we got to go see these patients when they overdosed or were bitten by snakes and all of that. And I'll have a lot more to say on that when we talk about like emergency medicine stuff in the winter semester. Anyway, so getting into it, so agonists are going to be basically anything that when it binds to the receptor then activates it. Right. So, for instance, when you have say you have a beta 2 receptor, I know you probably haven't gotten too much into the the autonomic nervous system yet, but let's say we have beta 2 receptors in the lungs, and let's say we have someone who has asthma and they're starting to have that bronchial smooth muscle constriction. It's starting to close down on those airways. We can give an agonist that will activate the beta 2 receptors, and that will actually allow for that smooth muscle to relax, right? So I can give a beta 2 agonist like albuterol. Many people probably have heard of that one. Give a nebulizer or an inhaler, and basically that helps to relax that smooth muscle because it's working as an agonist and it's activating those receptors. Thank you, Rachel, for saying that's cool. I need any validation I can get, and yes, I think toxicology is pretty cool stuff. So anyway, so that's an agonist effect. A few things we'll talk about when we get into specifically talking about agonists. We're going to talk about affinity. Affinity is basically how tightly a drug binds to that receptor. You can have things that have very low affinity that will bind to it, but it doesn't stay very long. Or you can have things that have very tight affinity or high affinity, and when it binds to that receptor, it sticks around for a long time. It likes to hold on to that as long as it can. That can be important. I'll show you some clinical instances where that will come up. When we talk about potency, potency basically means how much drug do I need to elicit a given response. You will find that things with very high potency, I don't need very much of it. Things with very low potency, I need a lot of drug in order to get the same effect. So for instance, we have 2 opioid analgesics here. So we have morphine and we have fentanyl. These are very common ones you'll see being used. Fentanyl more so like in the ER or the surgical realm. Morphine, you're going to see that used either outpatient, inpatient. Morphine's used everywhere. But to compare the potencies between the two, see, the morphine itself can be dosed in milligrams, right? So maybe I can give, if I'm giving an IV dose of morphine to a patient, maybe 4 to 5 milligrams, okay? for fentanyl to get the same effect, I'm giving 50 to 100 micrograms, right? 4 to 5 milligrams to maybe 50 to 100 micrograms. That's several orders of magnitude difference between those two. And so because of that, we can see that fentanyl is much more potent. So I don't need to give very much. So if you were to give 4 to 5 milligrams of fentanyl to a patient, they would be dead because they just stop breathing, because that is way too much fentanyl, right? And so it's important to understand when you're looking at different drugs, you're like, why am I giving 2 grams of this one, but I'm only given a few micrograms of this one? All that has to do with the studies that we've done to find out how much drug it takes to get those effects. And we'll talk about that relationship in the next PowerPoint we get to next time. And so ultimately what you care about as practitioners, right, is going to be how efficacious a drug can be. Because it doesn't matter how potent it is if it doesn't really ever get as much efficacy as you really need. You can have a drug with high affinity and very high potency, but if you need to get a patient with a blood pressure who's 20 points out of range and it only can get you 10 points down, that's not all that efficacious for your purposes. So clinically, we're going to look to see how efficacious drugs are, and that being much more potent than the potency. Important than the potency in determining how useful that drug is going to be. Okay, just know that when you're looking up like drug references and you are looking at different dosings for things, you'll see that, okay, well, I'm giving so much of this one versus this one. A lot of it has to do with those studies we did in the background to see how potent they are. So I mentioned efficacy is, again, the ability to get that maximally desired response. Sometimes what we'll do is we'll look at 2 different drugs and we'll see, well, how much of this one does it take to get the same effect out of X milligrams of this one? And when we do that, they're called equipotent, right? So when I said 4 to 5 milligrams of morphine is equipotent to, say, 50 to 100 micrograms of fentanyl, those are equipotent doses, okay? And you'll get a feel for that depending on where you work and what you get exposed to. But an example here would be 100 milligrams of drug A can be equipotent to roughly 10 milligrams of drug B, right? So you can see here that why, in order to get the same effect, you're given those different doses. All has to do with the potency, the affinity for the drug for that particular receptor. So there are full agonists, which means when it binds to that receptor, you're getting 100% effect, right? So basically you're getting just as much effect as you would get as if you had the natural endogenous ligand bind to that. So for instance, if I were to give someone a dose of epinephrine, say they were having an anaphylaxis, right? So their throat's closing up and their blood pressure is dropping, I can give them an EpiPen, right? Give them epinephrine. That's a full agonist to all of those adrenergic receptors like your alpha and your beta receptors and all of that. And when you bind up 100% of receptors that are available, you're getting 100% effect. Now, it's rare that we're dosing medications to where you're going to get 100% receptor occupancy, but that's, again, what would happen if you were to give them that much drug. So if we have full agonists, then it would stand to reason that we have partial agonists too, right? So basically, these are going to be things that bind to that receptor, and they have lesser effects. So maybe if you bind up the receptor, instead of getting 100% effect, maybe you only get 50% effect, right? And so you may think like, well, why would that be beneficial? Why would I ever use one versus the other? Well, maybe I don't need 100% effect. Maybe 50% is perfectly fine. Maybe this drug that only gets 50% effect is sufficient and it costs a lot less, right? So there's a lot of reasons why you may give less potent drugs or why you may give drugs that are ultimately less efficacious depending on the situation. So a lot of it, and this is an unfortunate thing for students in the medical profession, but when you ask for like, okay, what's the best answer for this, and it says, well, it depends. You're going to hear it depends a lot, and so you'll certainly hear that a lot out of me. But anyway, so looking at a partial agonist, if you imagine these 2 different drugs here, again, they're still binding to the same receptor. It's just that when it binds to it, you're going to find you only get that limited effect. So if maybe with the full agonist, you got a 10 millimeter mercury drop in systolic blood pressure, maybe you only get 5 millimeter mercury drop in this one. So again, partial versus full agonist. And if you were to look at a dose response curve, which we'll talk a lot more about in the next section, you'll see here if you're looking at concentration on the x-axis and then the response from the actual drug itself, that it doesn't matter how much of a partial agonist you give, even if I'm occupying every single one of those receptors, I'm only ever going to get a fraction of the response I would get out of a full agonist. Okay. So then there's also going to be antagonists, right? And some of you may think that I'm an antagonist to you, perhaps, with my tests and things like that. But believe me, I'm totally on your side. But antagonists are going to be things that when they bind to the receptor, they're going to bind to the receptor, but they don't activate it at all. Okay? They'll block it up and basically have no effect whatsoever. Okay, so most of the ones we're going to talk about are called competitive antagonists. So basically they're binding to the receptor and they're preventing other molecules from coming in and interacting with that. So say for instance you are really nervous about a test coming up, right? And so your adrenal glands are giving out all this epinephrine and it's binding to beta receptors on your heart and that's causing it to speed up, right? Well, if I give an antagonist, let's say a beta blocker, that's going to competitively bind for those same beta 1 receptors on the heart, and they're going to be able to bind to the and prevent epinephrine from interacting with the receptors. And now all of a sudden the heart rate starts to come back down because now you have a competitive antagonist blocking up some of those receptors there, right? There's other means to do this as well. For instance, there's like chemical antagonism where we can actually have a drug bind to an agonist and inactivate it. So for instance, with a lot of drugs we see used for like rheumatology, like a lot of those antibodies that we give, those are designed to actually bind up things like inflammatory mediators like tumor necrosis factor and interleukins and things like that. But you may even have other things like functional antagonism. So for instance, if you have a drug that raises blood sugar, but the patient's also on insulin, well, insulin lowers blood sugar, and I have this other drug that increases the blood sugar, that you can see how functionally they're antagonistic to one another. Sometimes that's done accidentally, sometimes it's done on purpose. Just depends on the drug and the disease state and all of that. So ultimately, though, most of the antagonists we're talking about are going to be competitive in nature, and when they bind to that receptor, no activation occurs. So you can imagine here, looking at the natural ligand binding to a receptor site, causing whatever normal cellular activity would occur, whatever change. If you have an agonist drug, that can bind to that same site and cause the same effect, versus an antagonist is basically going to be plugging that up and preventing the natural ligand or potentially drug from interacting with that receptor itself. Okay. All right. So to further elucidate on that, you can have even different types of antagonists where we can talk about the reversibility. Yeah, so Kelly's asking about like Narcan. I'm going to talk about Narcan in just a second. I'm glad you brought that up. That's a great example of antagonist. So when we talk about antagonists, they can also be reversible or irreversible in some cases. And so as you might imagine, irreversible ones are going to be having their effects lasting much, much longer. So for instance, with the NSAIDs, we have ibuprofen here, and then we have aspirin. If you're aware, we will use aspirin for cardiac protection. You may think, well, why do you use aspirin but none of these other NSAIDs? Well, it's because aspirin is actually an irreversible inhibitor on those platelets. It prevents the platelets from aggregating so much, and that helps to prevent myocardial blockages from happening in coronary vessels and preventing NMI from happening. So even though the drug may be eliminated from the body, the effects still last because it is sitting there bound to whatever its target is. Reversible antagonists are only going to be working while the drug is around. So ibuprofen, while there is some risk for bleeding because it affects the platelets too, just like aspirin, as soon as the drug's out of the system, the effects go back to baseline. And so that's one thing we'll see, that you can have benefits from using irreversible antagonists, or sometimes that's a bad thing. So we'll see depending on the situation, but those are two further types of antagonists you might see. As I mentioned, there's competitive versus non-competitive. Competitive really just means that it's a numbers game. So, for instance, when we talk about opioids and we talk about Narcan in a second, depending on the concentration of the agonist versus the antagonist, you may find that you can change the numbers of one or the other and get that desired effect. So, for instance, if I had someone who had an antagonist on board, it was blocking up all those beta receptors, say, for instance, like you're in that nervous situation, and you're blocking those beta receptors with a beta blocker. If I were to release enough epinephrine and norepinephrine, all those other things, to kick that antagonist off the receptor, now I'm going to get that effect again, your heart rate's going to go back up, right? In some cases, you may find there's non-competitive antagonists, and this is basically where the antagonist will bind to another site and actually changes the conformation of the receptor such that it makes it more difficult for an agonist to come to bind to it. These are less commonly seen, but I'll bring them up when they show themselves in Pharm 1 and Pharm 2. Just know that for the most part, competitive antagonists are going to be the normal that we're going to see for most antagonists. All right, Maruk, and I hope I'm saying that right. If I'm not, you can correct me. But would insulin and steroids be considered an antagonist relationship? That depends on the steroids you're talking about. So if we're talking about corticosteroids like cortisol or prednisone or dexamethasone, yes, that would be antagonistic because they raise blood sugar. Just like your cortisol raises blood sugar, and insulin then brings it back down. So you can find that's an antagonistic sort of relationship. It's more that functional antagonism that I was mentioning just a few minutes ago. So let's see how that dose response curve would change if you were to apply an agonist by itself versus a competitive antagonist in the mix there too. What you would see here is that as the good, I'm glad I pronounced that right. As the agonist concentration goes up, you can see the effect go up as well, right? This little cut point here would be if we had maximal receptor occupancy. So this is the maximum effect that drug could get if you say you had every single receptor bound up, right? So the agonists here, notice when I give the competitive antagonists, they're both fighting over the same site. There's only so many receptors to bind to, and so now they're fighting over it. So you might have heard them in the background, but I have a 2 and a 4-year-old, and they are definitely competitive antagonists to one another, because sometimes there's only one crayon, and both of them want it at the same time. So it is what it is. But if you notice, by increasing the agonist concentration, you can start to outcompete the antagonist, such that if you look up here, that ultimately if I give enough of that drug, I can overcome with just sheer numbers and still get near maximal effect out of that. Okay, so again, just know it's a numbers game here. By changing the concentration of either the agonist or the competitive antagonist, you can either bring that back up or back down. Okay. So this is a good example I like, and this is where Narcan comes into play. So we know we're in the midst of an opioid epidemic. Opioid deaths are rampant right now for a number of reasons. But one of the reasons why it's so dangerous is that when someone takes too many opioids, it causes respiratory and CNS depression. So the patient basically stops breathing and they die, right? So let's imagine we have 3 different drugs here. We have a full agonist, which is known as methadone. It's a drug that is commonly used when patients are trying to eventually get off of opioids altogether for opioid use disorders. We use that pretty frequently. There's a partial agonist here called buprenorphine, or Suboxone is a common brand name, which you might have heard of. And then we have the antagonist, which is naloxone. And so let's look at the differences between their effects when interacting with the opioid receptors that we have lying in the brain and in the spinal column. With the full agonist, you notice here that, as you increase the dose, you're going to get a lot of effect out of that because you bind to the receptor, getting 100% effect out of that, right? Versus a partial agonist, it doesn't matter how much of the drug you give, even if I'm occupying all those receptors, I'm only getting partial effect out of that. And you're like, well, why in the heck would you ever want to do that? Well, basically, imagine you have someone who's trying to get off of their opioids. The nice thing about buprenorphine, it's a partial agonist, but it also binds really, really tight to that receptor. So imagine someone's doing heroin, they get into a program where they're trying to detox off of that, and then they get put on buprenorphine. Well, they have this drug around that's really tightly bind to that receptor, and all of a sudden they relapse, and they go back and they try to do a dose of heroin. Well, because this is binding so tightly to that receptor, it prevents the heroin from really working, and it's occupying all those receptors, and you're only getting that partial effect. So this is why we do that, because ultimately it's safer for them to have this occupying those receptors than something like heroin, right? And so that can prevent them, even though they do relapse, they don't really get the effects out of it, and hopefully they'll be able to get back on the program, right? Now the antagonist is blocking all those receptors and preventing anything else from causing any effect, right? And so I don't know if any of you have had experience in the ER potentially where you've seen someone get naloxone, but it is an exorcism-like event if you give too much, and some of you can chime in if you've seen that before. But basically what happens is that you'll find that you will immediately, say you have someone coming in, they're breathing, 6 times a minute, not responding to sternal rub, very obviously opioid intoxicated. Maybe they're found with a bottle next to them by EMS, and we give them the antagonist. Yes, people get very angry. That is absolutely true. May need restraints, absolutely, because the problem is that a lot of these patients who are chronically on opioids, they are very used to having that around. That's their new homeostasis point, right? Body resists change at all costs. So when you give the antagonist and you knock all of that drug off the receptor, because naloxone binds so tight, all of a sudden they go into what we call withdrawal, and that's something we're going to talk about in a later lecture. Basically, their body's so used to having that effect around it, you take it all away, and they're going back to basically having all the effects of the drug reversed immediately. So they wake up, they start breathing again, but also things like the GI tract starts to wake up, and so you see they're going to start vomiting, they might have diarrhea. I remember I had one young lady who had overdosed on OxyContin, which is an extended release form of oxycodone, and she was found in her car by police. She got brought into the ER, and we gave her a dose of Narcan, naloxone. She immediately woke up, sat bolt upright, and she was like, "Why did you do that? Do you know how much that cost me to get that OxyContin?" It's pretty severe in some cases, but it's life-saving, right? Your patient's at least breathing, so that's a good thing. Let's see. I learned a lesson about being prepared for the administration that day. Yeah, absolutely. We had one patient who we were on rounds in the ER one morning, and the environmental services crew was cleaning up one of the ER beds, and the resident who was on it overnight was kind of looking kind of sheepish. And so the attending physician was like, well, what happened? He's like, oh, I did guy that overdosed on oxycodone, and I gave him some Narcan, and I didn't really get a desired response. He's like, what kind of response are you looking for? And he's like, well, I didn't get the response. He wasn't really waking up, so I gave him another dose, and all of a sudden they have what they call a code brown. I don't know if any of you have been present for a code brown, but basically the patient's GI tract completely woke up and had diarrhea everywhere. So that's why EBS had come in, and that's why the resident was looking kind of sheepish, because he kind of gave way too much. So yeah, it can be kind of icky. People are kind of gross, as it turns out, which is maybe why I went into pharmacy. But anyway, I went to the wrong field because I was right there in the ER for a lot of that stuff. Yeah, every Friday night, absolutely. Okay, so we talk about specificity. We have things that have high specificity and then low specificity. What I mean by that is that ideally, you want a drug that only works on one type of receptor, one type of tissue to get the effect you're looking for. If I have a drug that is being used to treat an arrhythmia, I only want that to work on the heart. That's ideal. Very rarely are you going to see that, though. But ideally, if I have something with high specificity, it's only going to be acting on that one tissue type, that one receptor type, and that helps to limit adverse effects, right? So for instance, with antibiotics, our antibiotics are relatively safe because they mainly just affect bacteria, and their receptor targets are much different than human targets, right? So that helps to limit toxicity. Now, with things with low specificity, they can affect a lot of different receptor types. They can affect a lot of different tissue types and cell types, and you see more adverse effects. So for instance, there's some old school antidepressants that were really quite dangerous because they had so many different effects on the autonomic nervous system that can cause arrhythmias and seizures. And the thing is when you give antidepressants to a depressed person, one of the big risks is they try to commit suicide. It's a low risk, but it happens. And so these are really dangerous drugs to give to patients who are depressed. So fortunately nowadays we have safer drugs that are more specific. So if you ever hear of like the SSRIs or Prozac, those are a lot more safe than what we used to have. Chemotherapy drugs as well that we use for cancer are really nasty too, because a lot of the old school ones, they can't tell the difference between a healthy cell and a cancerous cell. They look identical to them, and so they affect both. So instead of just treating a patient's leukemia, you see that their GI tract gets hit, so they get stomatitis and these nasty ulcers. They lose their hair. You can find effects on the nails, the reproductive system. And so that low specificity means more toxicity for the patient. So ideally we want to get away from that, but sometimes we just don't have the option. Another term here I want to bring up, something you probably remember from your organic chemistry course. Hopefully you haven't repressed all of those memories. But we talk about stereochemistry a bit, and I want to introduce this now because you'll see this come up. And you may even see it come up in certain drugs that you see, maybe on commercials and things like that. Note that drugs have the ability to be, basically have different versions of themselves depending on how the bonds actually line up with one another, such that you can have basically like a left-handed version and a right-handed version of the molecule, right? They look identical in terms of chemical composition and structure, but you can't superimpose them on one another. So it's kind of like your hands. Even though your hands, they're mirror images of one another, but you can't superimpose one on the other because then your thumbs are on the wrong side, right? So the reason why we care about that is because most drugs come as a racemic mixture, as 50% of the S enantiomer, and the enantiomer is just that one particular binding pattern, and then the 50% of the R enantiomer, right? So most drugs come as that. Well, we have found that in some cases that you can actually find that one enantiomer can cause the therapeutic effects, while maybe the other enantiomer causes some toxic effects. So some people got the bright idea to say, well, let's separate them out, and maybe we'll have more effective drugs that are safer, okay? Also, by separating them out, you get a brand new patent on that drug. We'll talk about drug patents in just a little bit. So I'll show you an example of why this could be used for some monetary gains in just a minute. But what that means is if you have a racemic mixture, so you have 5 milligrams of a racemic mixture, 2.5 milligrams is the S enantiomer, 2.5 milligrams is the right enantiomer. Now, why would you care about this? Well, sometimes you have to convert between different drugs. So if a patient comes in on a drug called levalbuterol, which is a left-handed form of albuterol, that 2.5 milligrams of that would be equivalent to roughly getting 5 milligrams of albuterol, the racemic mixture. And so another case would be the antidepressant citalopram and then S-citalopram, which is the S enantiomer. You can see here that again, citalopram selects 20 milligrams is equivalent to 10 milligrams of this, because that is the amount of enantiomer that is in that racemic mixture. So you should be able to look at a set of drugs and be able to look at them to see, okay, what's the conversion between these two if you were ever try to convert a patient from one drug to the other. That's kind of the concept I want you to get. But, ideally we'd like to do this for like really good therapeutic concerns or therapeutic reasons. But I like this one, this advertisement quite a bit. It's for Zizal, which was levocetirizine. And, most people are familiar with Zyrtec, which is otherwise known as cetirizine, is a generic. But I like this one. It says, wisely designed to be different. The active enantiomer of Zyrtec with no dextrocetirizine. It's like, wow, that sounds pretty good. I wonder how bad that dextrocetirizine was. And then it says, the clinical relevance regarding the absence of dextrocetirizine is unknown. Oh, so why is it smarter? Why is it wise to do that? I mean, it's wise for the shareholders because they probably got a lot of money out of that new patent, but okay. We'll see more about that in just a little bit. You may get a pinch of cynicism from me, but don't let that jade you. Keep your naive young eyes open and let the world go ahead and ruin that for you on its own, okay? Don't let me do it for you. Anyway, so something else we'll refer to is something called up and down regulation. This is a means for the body to try to respond to the presence of agonists or antagonists in order to maintain that sort of normal homeostatic sort of processes here. So down regulation basically means if you have a receptor that's constantly being activated, so say you give a drug and it's activating a receptor, activating, the body's like, whoa, we're getting too much activation. Let's go ahead and reduce the number of receptors available, and that way we get less activation. And so you end up finding that as you start to reduce those number of receptors, maybe just not as many of them are being transported to the cell surface, or they're degrading faster, whatever the case may be, there's fewer receptors. That ultimately means you're going to get a diminished drug effect. And so in some cases, you'll find that patients may not get the same effect of a drug over time. You have to increase that dose in order to retain that effectiveness. Okay, that's a process of downregulation that occurs there. The opposite can occur with antagonists. So for instance, if I were to give you a beta blocker, to block those beta receptors in the heart, you may find that by giving them something that doesn't activate the receptors, they say, well, we don't have enough activation here. Let's go ahead and up the number of receptors we have available, thus making them more sensitive to the natural ligands like epinephrine, norepinephrine, and things like that. We'll talk more about that in just a little bit. But some other terms here we'll see. One is called bioavailability. This will be important when we talk about our different dosage forms in a little bit. Basically, bioavailability is roughly the percentage of drug that through a given route actually gets into the systemic circulation, right? So if I were to give a drug intravenously, I'm giving it directly into the vein. Well, it's 100% of the drug getting in there, right? So that's 100% bioavailable. Some drugs don't get absorbed all that well when given via other routes. So you may find that like an oral drug gets totally metabolized in the GI tract, or it gets metabolized in the liver, and none of it makes it to the systemic circulation. That's 0% bioavailability. That's why we don't give insulin orally, because it's a protein and it gets chewed up by all those proteases in the GI tract. It has no bioavailability orally, right? Let's see, C-MACE, I'm not sure what the C is for, but would this be an example of a patient that's prescribed an antidepressant and they feel better and stop but repeat the cycle? Not necessarily. That's not necessarily in terms of the effects of the drug. And I mean, certainly you'll see that, right? So you have patients who will start to feel better. They're like, okay, everything is good. And then they relapse and they stop taking their medications, and all of a sudden their depression gets worse. You'll find that all the time. Oh, Kalia, sorry. Yeah, you'll see that all the time for patients who have their blood pressure under control. They're like, all right, good, my blood pressure's under control. And they don't realize that when they stop taking the drug, then it goes right back to where it was before. That's a little bit of a different process. This is more at the kind of at the cellular level. And I'll show you some good examples of when that actually becomes important in just a little bit, especially when patients do relapse. And so I'll show you that in a little bit. So to go along with bioavailability, we have what we call the first pass effect. And basically that means that when you give a drug orally and it gets absorbed through the GI tract, the first organ it hits predominantly is the liver. And when we get to the pharmacokinetic lecture later on, we'll see that the liver is the main thing that metabolizes drugs in the body. It's the main metabolic organ that we have there in terms of metabolizing drugs. And so it's going to metabolize a certain percentage of drug prior to it getting into the central circulation to go and do its thing. So I kind of talk about this as like the liver tax, right? So you might find drugs that have 100% first pass, which means it's going to get completely chewed up by the liver, and then none of it's going to make it to the systemic circulation. Or drugs may have 0% first pass effect, right? And so these are things that we take into account because potentially we can find that a drug is completely non-usable via the oral route because of this issue. Sometimes we can give it via other routes to skip the liver. So for instance, If you've ever seen a drug given as a oral disintegrating tablet, something that you can dissolve in the mouth, or if you've ever seen drugs given rectally, sometimes that is done to bypass the liver and to skip that first pass effect. Okay, we'll talk more about that again in the kinetic section later on. But to go along with that, sometimes we give drugs in an inactive state, and so that's actually called a prodrug. So we give a drug where it's, if you were to take it intravenously, the drug wouldn't do anything. But when you give it orally, and it gets processed in the liver, it actually gets turned into the active form. So for instance, here's a drug called lisdexamfetamine, which is otherwise known as Vyvanse. It is a drug we use for ADHD. It's pretty popular. I see it used a lot in the pediatric population. But what's interesting is that one of the problems with using amphetamines is that patients would crush their tablets. They'd have these extended release tablets that were supposed to deliver drug over a 12-hour period. They crush them up and they snort them. And they do that because, one, it bypasses the first pass effect, so they get all that drug into the system, and they get it really quickly, get all that drug at once. So you get a really good high off of it, right? That's why they liked it. Well, what if we gave them a prodrug and they tried to snort it? It actually wouldn't do anything because that lisdexamfetamine is not really active. It doesn't interact with where the receptors that amphetamines normally would. And so originally it was done as sort of an abuse deterrent. You have to take it orally, has to go through the liver in order to turn it to dextroamphetamine, the active product. Beyond that, it's just a pretty good drug, so that's why a lot of people use it. But that's originally kind of the design feature behind it, was to deter abuse by patients. Some other terms we'll get into includes what we call volume of distribution. This is basically kind of a theoretical concept, but it's kind of trying to tell us how widely distributed a drug becomes in the body. So once it gets into the central circulation, it's in the bloodstream, where does it go from there, right? Does it like to stay in the blood, or does it like to distribute out into the adipose tissue, right? So let's say, for instance, we're talking about something like THC, right? So you have marijuana, the main psychoactive component is delta-9 tetrahydrocannabinol, or THC, right? That's what gives you the euphoric feeling, that's what makes you high. Has anyone ever noticed like what kind of like products those are cooked into? A lot of times it's like brownies. You can sometimes see it like in using like in pizza, and usually like a lot of like fatty foods. The reason for that is because THC is really lipophilic. Yeah, butter, absolutely, you can use it in a lot of different cooking applications. Very fat soluble, absolutely right, Isabel. And so what we end up finding is that because of that, because it likes the lipids, that it likes to distribute really far out into the tissue. You won't find a whole lot in the bloodstream, but it likes to go hang out in that fat tissue for a long period of time. And that's the reason why you find patients who are, especially if they have like larger body habituses, if they are smoking, no pun intended, chronically, large doses, they build up tissue stores, because that's a very large volume of distribution, likes to hang out in that tissue. And that's why they can be positive on a urine drug screen for months, potentially. Like 6 weeks, 3 months, potentially, for someone who's like really using this really chronically. So it goes to show you that, like, the volume of distribution can have big effects on a patient. Maybe that keeps them from getting a job, so really big, long-standing effects. And we'll talk about some different disease states and different patient conditions that can affect this pretty drastically. But more on that later when we get to the kinetic section. So now what I want to do is get into routes of administration. So what I mean by that is basically, how are we administering these drugs? Am I giving it in the muscle? Am I giving it through the skin? In the vein? I want to kind of go over the majority of these, so you have kind of a feel for the positives and negatives, and kind of be able to compare and contrast different routes together to see like when one might be most appropriate, right? And so this is a good table, I think, not to memorize all the numbers and everything here, but to have a general feel for relative things like bioavailability or relative characteristics amongst different routes of administration. So for instance, here you can see that when we get something directly into a vein, I've already mentioned this, has 100% bioavailability, right? Also means that's really rapid onset because we're giving it right into the vein. So I'll talk about these in more detail, but you can kind of refer back to this to give you some ideas of the big takeaways that you can get from this table. So first one I want to talk about is the route of administration, and the intravenous route of administration. So some advantages, especially if you've ever been in a hospital or maybe a clinic setting where you want to get medications into the patient really quickly, this is the way to do it, right? And one of the things I'll talk about is the difference between central versus peripheral administration. A lot of it has to do with which vein you're actually getting into, or where exactly that drug, the catheter, is going to be exiting in the body. So for instance, if you were to get an IV started in your AC, for instance, on your hand, that's considered peripheral, right? Because again, it's far away from that from the heart, where it's eventually going to return to in the venous flow, right? Before it gets back to the right side of the heart. This can have different impacts on the types of drugs we give, on the concentration, and things like that. But it's easy to do, right? It's easy to get a peripheral line in a patient, relatively speaking. Also, the big benefits here is it's 100% bioavailable. You get onset really, really quickly, and it's really titratable. I'll talk about that in a second. When I say central administration, that's typically when you hear about like a central line or a PICC line. PICC line just means peripherally inserted central catheter. That's basically a line where the catheter itself extends up into the inferior vena cava, and the big benefit with that is there's a lot more flow going on there, so it can help to dilute out drugs much more quickly. And so the benefit of that is I can give bigger concentrations. I might be able to push drugs faster, because there's a lot of negative things that can happen if using drugs incorrectly in a peripheral vein. Here's an example of one. There's an anti-epileptic drug used for seizures called phenytoin. And if a drug were to accidentally, if you were to blow a vein and you were to get that drug infusing into the surrounding tissue, it's called extravasation or extravasation, you can get a lot of tissue necrosis. So if you look at this, it's called purple glove syndrome, that happens due to the fact that all that tissue has now been infused with phenytoin, and it's causing a lot of necrosis because the stuff is really, really harsh on the tissue. So that's a case where maybe using central lines would be a better option for that patient, right? And so it's a big issue we had to deal with when we had shortages of alternative drugs. We had to use phenytoin, especially for little kids. Like little kids, their veins are extremely tiny, much more difficult to get good IVs in those type patients. And so it's something we were really concerned about there, right? Now, when you give something IV, you can either give it as what we call intermittent doses or boluses. So if I were to give, say, a gram of drug over 30 minutes, that would be an intermittent dose, because I gave it over a predefined set of time, and that's it. It's one dose. It's a bolus dose, right? Or I can give things via continuous infusion. So if you ever hear like of an epi drip or dopamine drip or things like that, those are drugs that are being given continuously. And the benefit of that is that they're very titratable. When I say titratable, that basically means that you can up or increase or decrease the dose as much as you need to get the desired effect. So let's say I'm giving a patient a dopamine drip because their blood pressure is low. If their blood pressure is too low, I can up that continuous infusion to a higher rate to give them the dose they need to get to the pressure I want. But now the pressure is too high. Now I can titrate the dose down. So because of that, it's very titratable, as opposed to like an oral medication I'm giving every 24 hours. You only get the one-time dose, and then you gotta wait till the next day to be able to alter that. So that's one benefit of using continuous infusions. You'll see that a lot used like in the surgical realm or in the ICU, places like that. Some other things to note too that we have to worry about is the fact that drugs may not always be compatible with one another. Here's an example of what happens if you were to mix calcium and phosphorus in the same tube, which can happen with different electrolyte solutions. You see that crystallization that occurs. Well, if that happens in your line, that line may be ruined, which means you might have to replace it. Or that can actually get into the patient and can lead to like an embolus in the lung potentially. So you have to think about things like chemical compatibility, and that's where a lot of your pharmacy friends are really going to come into play. A lot of nurses are really good at knowing which drugs are compatible with one another, so that can really help to save you instead of making a mistake like that. The other big thing to note here with the IV is once you give it, especially like a big bolus dose, that's it. You can't really take it back. Once it's in the system, that's it. And so you have to make sure that you're doing the right thing the first time, because you may not get a chance to really correct that. What would happen if, though, I couldn't get an IV started? Say I got a patient who is actively coding, their heart has stopped, and the patient is unable to, or the provider is unable to get an IV. Well, fortunately, we also have these really big non-compressible veins, essentially, called our bones. And so we can actually use what we call the intraosseous route of administration. And so here's an example of an easy IO kit. Basically, these big thumbtack things are needles, and you can then use this little power drill to actually get into various bones. And based on the size of the patient and the bone you're going into, use different ones. And the benefit here is it will then go into the actual marrow of the bone itself, and you can infuse anything you want through that. You could do continuous infusions, you can do drips, you can do antibiotics, anything. And the easy thing here is you just gotta aim and drill, and then you're kind of good to go, as opposed to a vein, which can be more difficult to get. So we use this a lot, especially like in emergent situations. If we were to do this for like say a small child was coding, and then you could then infant coding, The vein was too compressed, couldn't really get an IV started. IOs are the thing we're going to do there. Okay, you can see here the different bone areas you can actually use. So in Pulp Fiction, Kyle asks, like in Pulp Fiction, no, because they're actually trying to do like I believe they're actually trying to get the epinephrine into the heart itself. So it's almost like they're trying to go through the sternum and into the heart. I would not recommend doing that. Also, I would not recommend snorting heroin. That's also pretty bad for you. Cocaine as well. I would not do that either. Big takeaway, don't do drugs. Drugs are bad for the most part, except when I tell them it's okay to give them. But yeah, so actually I think they're trying to get through the sternum into the heart itself. Let's see, they're so nice to have on hand in the field. Yeah, so easy IOs are great to have. Actually, I had one mishap happen. We actually had a patient, as an adult patient, who came in with a cardiac arrest, and he had an IO in the sternum. And unfortunately, when the patient ultimately didn't make it, but they were trying to clean the patient again, ready for the family to come view him. Unfortunately, the actual plastic bit here that we'd use to kind of unscrew from the bone fell off. So then we just had this like needle like sticking out of the patient, and we had to ultimately get like a pair of pliers, I think, and yank it out. So they're not perfect, but they're pretty good for the most part. All right. So anyway, yes, because that did happen. Other routes of administration. So let's say we don't want to use something IV. What other routes can we do? We have sub-Q, right? So this is actually where you would inject into subcutaneous tissue. Typically, the abdomen is used most commonly. The reason why we like this is because you can have patients administer this themselves. So if you think about insulin administration, this is what they're most frequently doing. But other things you could do too. You could have like implants that could be placed, like certain, I mentioned buprenorphine used for opioid use disorders. You can have implants of that being placed. Birth control can be placed subcutaneously. So a lot of uses for this. It does have pretty high bioavailability, but if you want to think about the onset of action as compared to IV sort of being the fastest, this is relatively slow, but that's okay, right? If you think about like insulin doses, like a long-acting insulin, I don't really need that to be absorbed super fast, and so it's okay if it has a little bit of slow onset, versus if I need like epinephrine for someone who's in cardiac arrest, I want that to work right now. So sub-Q administration may not be as appropriate in that sort of situation. Some disadvantages, obviously, is that patients tend to not like to inject themselves. It's painful, minimally painful. And also, if they don't rotate sites appropriately, you can end up seeing things like lipodystrophy can occur. Sometimes, like anticoagulants, you can actually get a little bit of tissue necrosis and happens, ecchymosis there. And infection is a risk too, right? So they have to make sure they're using good aseptic technique to keep everything sterile and make sure they don't accidentally give themselves like a skin infection potentially. Next, we have the intramuscular route. So this is done frequently. You'll see this all the time for certain vaccines and things like that. Or we do this a lot in the ER if patients don't have IV access, and maybe we don't want to get IV access because they just need a one-time medication. This may be a good route for that. So if you have, say, someone comes into the ER and they're vomiting, so they can't take oral antibiotics, they have an ear infection or something, we give them an IM dose of antibiotics, and then they're good to go. They're done at that point. Pretty fast onset, not as quick as IV, but still fairly fast. And the disadvantages, though, can be numerous. So because you're injecting this into the actual muscle itself, there's not a lot of room for extra fluid. As opposed to the subcutaneous tissue, there's a lot more give there. It's mostly just, some skin and some subcutaneous fat and things like that. There's room for expansion, right? In fact, you can sometimes even give, if you're familiar with any animal lovers that are out there, if you have to give fluids to dogs or cats, they normally do this as sub-Q administration. You can do the same thing to people, actually. I've seen cases where they've infused a whole liter of fluids into someone subcutaneously. That's totally appropriate because there's a lot of give there. With the muscle, though, there's not as much room to do that. So we have to give very concentrated drugs in relatively small volumes because the pain is going to be pretty bad. So like 3 mLs is kind of the most you can do that to. Doing that to a cat is not fun, I can imagine. Doing it to people too, because they're like, I have to give because we usually do it behind, between the shoulder blades. So it kind of looks like they have a camel hump. And so that's not particularly attractive to patients, but it's sometimes good if you don't have the ability to get an IV, it could be used. But anyway, so like 3 mLs is like the max you could do in an adult patient before pain is going to be pretty severe with that. So not only that, but you also have to think blood flow needs to be circulating around in order to make sure the drug gets absorbed. So in case we have like a hypotensive patient, they may not get all the effect or maybe delayed because it's not getting absorbed all that too well. In case you have patients that are on either extreme of weight, they may have altered absorption. and you may even find things like exercise or heat can actually affect absorption as well, maybe increasing that because muscles are moving, it's hot, they're going to be picking up drug more quickly, more faster. It's not proper English. Common injection sites you're going to see include things like the gluteus maximus, the deltoid, vastus lateralis. Those are pretty common ones. You'll see for vaccine administration, antibiotic administration, things like that. We even have intrathecal administration. This is good for things that need to be delivered directly into the CNS. We can do this in some cases with like chemotherapeutic drugs. We can do this with antibiotics, or the more common thing you probably think about is like epidural anesthesia. So you can think about things like patients going into labor. Placement is really important here because depending on where and how the patient's positioned and how you're given the drug, you want to make sure you actually want getting into the actual intrathecal space. You also want to make sure you don't get into any surrounding veins or anything like that. Some of the drugs we give into the intrathecal space can actually be really toxic if it were to get into the veins. So you have to make sure placement is really good. This is why you have like your anesthesiologist, your CRNAs do it, but you may do it occasionally too, especially if you're doing a lumbar tap. The same process is essentially happening here. Spinal headaches can be somewhat common because you're going through those different layers of tissue into the CNS, so that's a common side effect you'll see with that. But we can talk more about that later when we get into talking about anesthesia in a couple semesters. Then we have the sublingual route. This is a good one for patients, especially if they're like nauseous and they don't want to swallow anything. And so most people are familiar with the drug Zofran, or ondansetron is the generic name. That stuff is like, we give it out like water at the ERs because if you're nauseous, it's a great drug to have on board. And so not every drug can do this. It's relatively uncommon, but if you ever see like an ODT, an oral disintegrating tablet, that usually means it's a sublingually absorbed drug. Nitroglycerin is another really common one you'll see used that way. And again, it's good for patients who can't swallow or if they are actively vomiting. This is a good one to at least get some absorption. Because again, this is all mucous membrane in here, and so you're going to be able to get good absorption from that tissue if the drug is available to do so. Some drugs just can't cross that membrane very easily. And again, keep in mind that this does bypass that first pass effect, which is a benefit. It's more bioavailable essentially. Let's see. This slide's going from fastest to slowest in effect. Not necessarily, because I'd say like IM is probably a little bit faster than a little bit faster than sub-Q. IV is obviously the fastest, so I would not say that. You can probably look back at I think if you go back to this slide here, it'll kind of give you an idea. This is probably pretty close. If you just look at these five, you probably see kind of from fastest down to slowest. Rectal inhalation, transdermal, these are going to be more specialty case. So we'll talk about those as we get into them. Okay, so anyway, sorry from blasting through these if it's going to give you any epileptic fits or anything like that. I apologize. But so next we have oral. So oral is certainly the most common way you're going to be giving medications. It's relatively safe, it's economical, it's just what we do for a lot of patients. It does require compliance, so you want to think about the dosage form you're giving. There are adult patients who cannot take tablets. Some people just have aversions to that stuff, and so you may need to change the dosage form up. You may have to go to a liquid formulation, or if you have a Parkinson's patient who has dysphagia and they can't really swallow, they can't coordinate enough to swallow, they may need liquid medications. This is going to be subject to first pass, right? So you have to make sure the drug is actually going to be bioavailable through that route in order to use it orally. And then this is going to be prone to a lot of food and drug interactions. So for instance, here's a class of antibiotics called fluoroquinolones, like ciprofloxacin and levofloxacin. It has a tendency to bind to calcium in milk. So let's say you have a patient who comes in with a UTI. Say you have an older patient, she has like chronic cystitis or something, or you're treating for a UTI. You give her fluoroquinolone. But older patients are worried about osteoporosis, so what do they drink a lot of? They drink a lot of milk, right? That calcium, if they take it at the same time as the fluoroquinolones, can bind that up, and now they don't absorb it. So the patient's UTI doesn't get any better, and then they progress to, say, urosepsis or something, as a result of the fact that the medication was never absorbed, never worked in the first place. You may think, wow, maybe this is a really resistant bacteria, when really it's just the drug was never absorbed to actually fight the bacteria that it was susceptible to. So those are concerns. We'll certainly talk more about that in the antibiotic section next semester here. Now, there's a lot of varieties of dosage forms you can see with the oral route. There's what we call enteric coating. This is actually a means of coating a drug with a acid-stable sort of coating. So basically, if you have a drug that normally would be destroyed in the pH of the stomach, like pH of 2, you can coat it with this film, basically, that will allow it to pass through the stomach, basically without it being affected. And then once it gets into the higher pH of the small intestine, that coating will then melt away, and then the drug can be absorbed. So sometimes you'll see that if you look in like over-the-counter omeprazole, or Prevacid or Nexium or something like that, you'll actually look at the capsules. They actually have these little pellets in it. Those are enteric coated, essentially. So that way they're able to get through the stomach. Then they'll dissolve in the small intestine and can be absorbed. We also have a lot of controlled release preparations as well. These are good for drugs that need to be absorbed throughout the day. So if you imagine like amphetamines we use for ADHD, you're giving your kid Vyvanse, or you're giving them Adderall or something like that. Typically, instead of having to give them a short-acting medication, we have to take it multiple times throughout the school day. That can be really problematic, especially because it's a controlled substance. You give them a long-acting drug that works, you give it one time and it works throughout the day, then they're okay. They don't have to take any more doses. So that's one benefit there, and it helps with compliance. And we're going to talk a lot about compliance as we go forward, and how to help patients be successful with their regimens. Then we have the rectal route. This is good for patients who can't take PO meds. We do this a lot for infants, glycerin suppositories and Tylenol and all of that. You will bypass significant amounts of first pass effect by doing this, by bypassing the liver. However, you're going to find that depending on the patient, they may have incomplete absorption of the drug. So basically what you find with these suppositories is that the drug has been mixed in with this cocoa butter base, and it's designed to be a solid at room temperature. But then when it gets into the rectum, when it heats up to body temperature, it then melts and allows the drug to be absorbed. Well, what happens if you have someone who has, increased rectal contractions, say they're an infant, and they, they have bowel movements 6 to 8 times a day. Well, if they, eliminate it before it has a chance to actually dissolve and absorb, then the drug's not going to work all that well, right? So I hear a lot from my parents. They're trying to give their infant, Tylenol suppositories, and they give it to them, and then they go and they check the diaper later, and they see the suppository melted there on the diaper. Like, that's not going to work that well, because that's not where it works. So that's an issue. Also, patient compliance can be a big thing. An infant, they don't really care if you put something suppository in rectally. Adults probably don't like that. It's a very uncomfortable sort of thing. It's like enemas and things like that. So we'll talk more about that when we get to like specific indications for those a little bit later on. We'll see this especially with like ulcerative colitis and things like that. One thing, note, please take off this foil wrapping, otherwise it's going to be a major pain in the rear. So just note that. Okay. Up next, we have the inhalational route. This is good when you're trying to get drugs just to the tissue you want, or in this case, oftentimes it's just the lungs. So we do this a lot for like asthma medications, and for drugs that get absorbed from the lungs, it can happen really, really fast too. So if you think about like crack cocaine, which is frequently smoked, that's a really fast onset of action, and that's the reason why that works so fast, is because it's getting absorbed from the lungs as opposed to say snorted through the nose or injected IV. It's actually even faster than IV in that case there. The disadvantage though is it's really technique dependent, depending on how you're giving it. Normally, if you have someone who's not going to be compliant, say you have like a small child or someone who's maybe fighting you, that's when you can use like a nebulizer, or basically put the liquid drug into a nebulizer cup that will then aerosolize it, and they can kind of passively just breathe it in. But for more targeted techniques, things like meter dose inhalers, so this is an example of a meter dose inhaler, or there's things like dry powder inhalers, where patients actually, there's a dry powder, and so they provide the inspiratory force to actually inhale it. That requires much more technique. And so if your patient, say, has COPD and rheumatoid arthritis, and their joints are such that they can't even operate the MDI, well, that's not going to be very effective for them, right? So we'll talk more about this when we get into the pulmonology section, but this is something I wanted to note first. This is another good point too, when teaching patients about how to use medications appropriately. Like, technique is super important, and this is where we do what we call the teach back method, where you show someone how to do something and you say, okay, now you tell me how to do it, to make sure that you got the point there. So I like this is a really good example of the teach back method, showing some underlying misunderstandings of how this lady's going to use her inhaler. And you may think that sounds completely silly. Why would anyone ever do that? But I can assure you it has happened in the past. So just note that if patients can't do something, they likely will do something. So moving on, next we have the transdermal route. So this is good for drugs that basically you will find if you need something that works over a long period of time, but you don't really need all that fast of an onset, transdermal drugs tend to be pretty good. And so, for instance, like we can change these maybe every 3 days, 7 days. It's good for patients' compliance when you don't have to think about changing every single day. Amber says, shadowing showed me so many people don't know how to use their inhalers. Absolutely. It's terrible technique, and that's why I really appreciate our respiratory therapists and the ERs and stuff that can help to catch that sort of stuff and educate them. That's frequently why they come in for their exacerbation in the first place, because their drugs weren't working effectively because they weren't using them properly. But anyway, that's another soapbox I'll get on a different day. In terms of disadvantages, though, not every drug works via this route, because drugs have to be able to penetrate the skin, right? So if you have something that is impermeable to the skin, it's never going to work. You also have to make sure patients don't use it on open wounds, because that can actually increase absorption. And I worry about this stuff too because of the risk for poisoning. Just because this works on the case of diffusion, so you have to have a lot of drug in the patch in order to drive it across the skin. Excuse me. So to allow that to happen, you have to have a lot of drug in the patch to cause that diffusion gradient to happen. Well, when you throw that away, all that drug there's still some drug left over, and so if like a kid gets into it or an animal gets into it, it's a big risk for poisoning. So that's a big concern. I've had several kids that have come in for eating one of these out of the trash, and they get really, really sick from that. So be cautious with those. There's some other routes too. We'll talk about them as we get into specific topics. So when we talk about HE&T stuff, we'll talk about ocular pharmacology. We'll talk about how to give eye drops, and we'll get into those a little bit later on. So there are other routes, but I went over the kind of the major ones you're going to see most commonly. So briefly, I want to talk about drug development here. So when I say drug development, what do I mean? Basically, it's like the process for how drugs get from the research stage into your hands where you can actually take it as a patient, right? JMFL, I'm not sure who that is, but I've rolled unconscious patients over on scene to find like 30 transdermal opioid patches, and I've heard of people attempting to shoot the product from patches. Yeah, that depends on the type of patch it is. There's some that have been designed to try to prevent that. One thing people will sometimes do is they'll apply heat to like a fentanyl patch, and that actually helps to increase absorption, and people have died from that. Or they have like chronic pain and they accidentally kill themselves because they get into a jacuzzi or something, and all that heat causes the drug to absorb really fast. But another good point of that too is whenever you're assessing a patient, always make sure you completely undress them. Because I can't tell you how many times that, especially in the ER setting, if you don't do a good full head-to-toe exam and you miss a patch, that can sometimes be antagonistic to what you're trying to do with the patient. If they have a patch on lowering their blood pressure and they're hypotensive, if you don't take that patch away, doesn't matter how much drug you're going to give them, you're going to be fighting yourself a little bit. So again, make sure you do a good full exam to find those patches and get rid of them if need be. But anyway, getting into the FDA, so the Food and Drug Administration, they don't just deal with drugs, they also deal with food, and they also make sure the cosmetics you wear are also safe and appropriate to use. So they actually cover quite a few things here. Okay, so it's Jackson. There you go. No, I don't care what accounts. Hopefully, no one's username is anything like particularly egregious. Otherwise, I may ask you to change that. But so there's a couple of laws that came through, and frequently we have laws that happen because something really terrible happened and made us realize, oh, perhaps we should have a law to prevent this from happening again. So really history repeating itself. So basically what we end up seeing is that things like, poisoning scandals have happened. This is where we get different laws that happen. I'm sure some people might have heard about the drug thalidomide. If not, we're going to talk a lot about that in the pregnancy talk, where we talk about drugs being teratogenic and causing birth defects in children. And so because of that, we had to have these laws put in place to actually show that drugs are safe and effective. Before, back in 1906, which isn't that long ago in the grand scheme of things, you could put really anything out there. That's why you always see those like old-timey advertisements for like, your toothache drops that are like have a ton of heroin in them and stuff like that. I mean, those are the good old days apparently. But since then we've realized, perhaps it's not great to put heroin in, simple toothache drops, and we should probably show they're safe and effective. So stuff that seems common sense is not quite that common until the laws are put in place. So anyway, so when we talk about human testing, so say a drug company is going through and they found a drug, they tested on animals in the preclinical setting, and they say, okay, this looks good. We think we have a drug we want to market to people. This is where it gets into the clinical phase, right? We're actually giving it to people, doing clinical testing. They have to apply for what they call an IND, or an investigational new drug application. This is basically the FDA looking at their data and saying, okay, we think it's okay for you to start testing in people, okay? From there, they have three main phases of clinical trials. Okay. The only reason why I mention this is because that way you have at least some context for how drugs get onto the market and things like that. Basically, phase one, they're really only testing in healthy volunteers, right? Which is interesting because you're thinking, like, if I have a blood pressure medication, I probably want to give it to people with hypertension. But the first phase, we don't really want to know about that yet. We want to make sure that the drug is actually safe and kind of what doses we need to administer for the drug to work. So you may find you're only testing like 10 to 100 healthy volunteers, okay? In phase two, once you pass that, then you're starting to give it to more patients. Maybe you're giving it to a few hundred of people with the disease in question to determine how efficacious it is. So now you're dealing with people who actually have the disease that you're trying to treat, and maybe a couple hundred. Okay. Now phase three happens. These are the largest trials they do, where they put it into thousands of people with the disease to make sure that it works. This is maybe where you find some placebo-controlled trials to make sure it works better than placebo and things like that. And then from there, once they pass that, they take it back to the FDA. They say, okay, we'd like to take it to market. We think it's safe and effective. And then they say, okay, you're good to go. And then that's where a new drug comes to market here. And again, there's thousands and thousands of chemicals that never make it to market that have been studied. You know, maybe you imagine in the basic research section, you know, like thousands of chemicals that don't really pass muster. They get up into preclinical testing, we're doing on animals, and then you get into these very small number of drugs that actually do make it to market. So you don't know why drugs are so expensive. One of the reasons is because you got to pay for all this research for all the stuff that failed too. So a lot of that is going back into the R&D aspect of it to make sure that they can continue on to find that next one drug out of the 25,000, right? So that's one thing you'll see there. So one of the other interesting things with drug development too is the fact that once you get that IND, you have 20 years on the patent for that drug, 20 years in total. Once 20 years expires, then you can start to make generic drugs. You can see that right here on the very far end. Generic drugs become available, right? Which are cheaper and are generally work just as well as the actual brand name drugs. So drug companies, it's financially makes sense for them to make sure that they get through that the trial phase as fast as possible. Because if it takes them 15 years to get through your phase 3 trials on a market, you only got 5 years to make up your money. So that's not really financially incentive to them. They want to get more years out of that. So that's one thing you'll see. And again, when that drug company made Zyzal, which was the levocetirizine, they were able to get through that a lot faster because they already have cetirizine with a proven safety record, and now they have a new patent and they have a lot of years they can make money on that. So goes to show you. Anyway, another thing to note here, the phase 4 trial, I didn't mention that. This is called post-marketing surveillance. What does that mean? Basically, imagine, you get through phase 1, 2, and 3. You've only given the drug to maybe say on the outside, 10,000 people, right? Well, what happens if you have a drug that's has a 1 in a million side effect, or 1 in 2 million? Well, you're never going to find that if you're only giving it to a couple thousand people. So this is what we call post-marketing surveillance, where now that you are on the market, people are taking the drug, we're going to be monitoring for new side effects that pop up. We can report that. Providers can do that. Pharmacists can do that. And we report it up to the FDA. And in some cases, if we start to notice things like, oh, the patient had a heart attack and they're on this drug. And okay, we've seen a whole bunch of people pop up that have a heart attack while on this drug. In some cases, we've removed those from the market, right? So you hear about a drug being pulled, it's because of those issues there, the post-marketing surveillance. And in fact, if you've ever taken a drug at any time in your life, guess what? You're a participant in a phase 4 trial, right? And just a good example of this would be ranitidine, or Zantac, was actually removed from the market within the past year or so because of the fact they're starting to realize that when the product is left in heat, it produces a known carcinogen. We've used Zantac for decades, and all of a sudden we're taking off the market. It's because of these post-marketing surveillance we've been doing to make sure that the stuff is still safe, even though we want to take it for granted. It's not always the case there, right? So here's another slide kind of showing you the general cost of things, getting through these different phases of trials, and kind of reiterates what I've already said, so you can refer back to that for when you're studying. And again, the average cost to get a drug to market is like $2.6 billion. It's probably an old figure. It's probably gone up since then. But it is a very expensive process. that does not justify the cost for a lot of these medications, especially really old medications like insulin and stuff like that. But you can see some reason why that medications are expensive, especially when they first come out and they're still brand only. One of the things we'll see, though, is when that 20-year patent sort of expires and you want to start making generic drugs, this is where we talk about bioequivalence, and this is how companies can show that their generic works just as well or the same as the old brand name drug. And so by doing that, they can show that they work exactly the same. They can show in the graphs and everything that, okay, the kinetics are exactly the same. It's just as effective. And then the FDA can say, okay, you're approved to make that generic. So that's a term we'll use sometimes to talk about the difference. Because sometimes you have patients who will say, well, only the brand name works for me. And that's generally not true. For the most part, generics work exactly as well as the brand name. There's some exceptions, but for the most part, that's the case. See, Kyle's asking, do you know why so many drugs have gone on recent back order, more specifically drugs like losartan, valsartan, etc.? That's actually the same issue in those particular cases as was for ranitidine. There's a product called NMDA, I believe. NDMA? I believe it's NMDA, but it's a known carcinogen, and so it's a nitrosamine product, I believe. And so, actually, I think it was valsartan was one of the first ones that actually got caught on that. They started to notice that there was some contamination that has to do with the actual synthesis of the drug. The drug itself isn't carcinogenic. It's the fact that it had this contaminant that's in it. And so they started to recall that out. And actually, I had a family member who was on valsartan, and I mean, I can't imagine being in the retail pharmacy realm. Now, I'm a clinical pharmacist, which means I work in hospitals predominantly. So, retail is not really my thing. I'll tell you a story about that later. But I couldn't imagine having to take all those patients on valsartan if I work at CVS or Walgreens, having to call them up, call their docs, whoever, and get them switched over to a different drug. It must have been hellacious. But regardless, it had to do sometimes with contamination. Sometimes back order is more, you must have experienced some of it. But yeah, sometimes it has more to do with shortages can happen for a number of reasons. We had cases where sodium chloride went on shortage. And we're like, it's sodium chloride, it's salt water. Like, what are you talking about? But it can have things to do with like the actual the plants where they're made. There could be a safety regulation issue that pops up. It could be due to, we had one drug go on back order because there were particulate pieces of glass coming off of the vial getting into the medication. So there's a million different reasons that are out there. Yeah, honestly, having everyone to switch over only to have the new drug to go on back order too. Yeah, so, and then too, if you're not counting on everyone switching over to that one drug, then you run into issues. I had a family member who was taking ranitidine or Zantac for forever for their GERD symptoms, and now they had to switch over to famotidine or Pepcid. Well, everyone else had to switch too, and so now that drug's on back order because they weren't expecting such a big ramp up in demand. So, drug chain issues are common. And you as providers, you may think like, well, okay, the pharmacy is going to deal with that, but you have to deal with it too, right? If you have a patient who needs a specific drug, but pharmacy calls you up, says it's on back order, what else do you want? This is why we train you to know, like, what's the backup? What do you use as your second line drug? What's your third line drug? That's one of the skills we'll teach you about in this class as we go forward. Here's an example of what it would look like in terms of bioequivalence between two different medications, a brand name versus generic. They'd have to show that they're within a certain degree of difference with one another to say that, yeah, these are bioequivalent. They're good to go ahead and substitute one for the other potentially. Because as a pharmacist, one of the goals is to give the patient the most cost-effective medication. So if you write for a brand name drug on your prescription, I can substitute that out for a generic as long as you don't write a specific thing, which I'll talk about later, because it's cheaper for the patient. See, my bestie is a retail pharmacist, and she's not happy right now with that going on. I cannot imagine. I would not be a happy retail pharmacist in any situation. But God bless them. They're doing good work out there. Hopefully it'll die down at some point. But retail pharmacy is a whole nother beast for sure. Okay, so the thing I want to sort of end out on is talking about receptor signaling. So we talked a lot about what receptors are and what they can be. I want to get more specific into that and talking about where they lie, what type of receptors do we have available to us, and things like that. So that's how we'll kind of round out this section here. Now, normally we know communication between cells depends on these signaling molecules. So for instance, if your pancreas is detecting there's too much blood sugar, it needs to tell all those cells in the muscle and the fat tissue, okay, we need to start absorbing this glucose to get the blood sugar under control, right? And that signaling molecule is insulin, okay? And there's a million different signaling molecules out there for your immune system, for your blood pressure, for your depression, for all kinds of different stuff. Signaling molecules are really important here. And so basically when I'm talking about the effector pathway, I'm talking about from the signaling molecule coming in interacting with that receptor. We call that the effector. And then we talk about what we call secondary messenger systems. The first messenger is whatever came and activated that receptor in the first place, right? We'll talk more about second messengers in the next section coming up, but that's basically all the downstream things that happen. So a drug binds to a receptor and causes a whole bunch of stuff to happen that lowers blood pressure, fixes your depression, fixes that arrhythmia, whatever the case may be. There's a lot of secondary signals that happen. We're going to talk more about that. But now I want to focus on the actual receptors themselves. And there are different ones, right? We can have, say, for instance, like cell signaling between cells that are in direct contact with one another. Oftentimes, this is useful to help with things like immune function. Say you were to be exposed to something you had a vaccine before, vaccine 4 years ago. This is how some of that cell signaling will then trigger those cells to start producing new antibodies, for instance, right? We can find, you can have paracrine signaling, which is where cells can kind of transmit by releasing these mediators to other cells within the general vicinity. That's one way to do it. Some of the ones that I'll talk about more frequently are typically, especially when we get like the neuro section and we talk about like the autonomic nervous system and epilepsy and cardiac signaling, all kind of stuff. I'll talk about synaptic signaling too. This is really important. We actually have a neuron that will release neurotransmitters directly onto a cell. We call this the synapse here. This could be a nerve going to the muscle. It could be going to brain cell. It could be lots of other different types of tissues here we could be dealing with, but the synapse here is the really important part. So I'll get a lot into that. I'm talking about neurology and behavioral health for sure. And then another really common one, especially when we're talking about hormones and things like that, are going to be the endocrine signaling, right? So some distant cell is releasing, say, for instance, your thyroid's releasing T3 and T4, thyroid hormones, into the bloodstream to then go through and affect different cell types, right? And this is important because you can affect all the tissues of the body this way, right? This is kind of like applying a drug, but your body's doing it from one specific tissue type to affect cells all over the body. So if your adrenal glands are releasing cortisol into the bloodstream to affect glucose, to affect inflammation, to affect all kinds of stuff, it is related to this endocrine sort of signaling, right? But let's look at the different receptor types that are out there. So we can have enzymes that could be receptor types. So for instance here, you can find that we can either activate enzymes or we may be able to inhibit them, right? Here's a good example of the enzyme dihydrofolate reductase being inhibited by the drug methotrexate. This is really important for rheumatologic conditions, for cancer treatment. And basically what you can see here is that the methotrexate prevents this enzyme from utilizing folic acid. It prevents it from being recycled through here, and ultimately that prevents the cell from making new DNA. You can't make new DNA, cell undergoes apoptosis, and then boom, cell's dead, right? Other drugs can do that as well with different enzyme targets. There's one called 5-fluorouracil, 5-FU. It's not a slur, it's just, it's not something you want to say to your friends necessarily, but it's a common shorthand for that particular drug. But point being is that enzymes can be the target in some cases, right? For testing purposes, don't memorize this specific example, but I want you to just know different types of receptors that are out there, what could be targets. Here's an example of a transport protein being affected, right? So you can actually find that you can affect things like ion transporters, and that can help to inhibit that or help to stimulate those to change ion concentrations within a cell. So for instance, when you're looking at the drug digoxin, this is a common one we use for certain types of arrhythmias and AFib. This actually affects the sodium potassium ATPase pump. It actually inhibits that pump, and this can then cause downstream changes in ion concentrations to allow for the heart to contract more strongly, right? To allow for more calcium to flow, to allow for to bind more tightly. And so again, just a different type of receptor that could be a target for a potential drug, right? Here's one where you can actually target structural proteins. So for instance, like colchicine, we use this a lot for gout, and actually can affect things like mitotic spindles that can help to inhibit the locomotion of inflammatory cells when you have a patient with gout and their big toes hurting really bad because all that uric acid is crystallized out. This can help to decrease that inflammation, right? So to get into that, there's 4 main drug receptor types I want to get into the brief time that I have here. So we have ion channel receptors, G protein coupled receptors, enzyme linked receptors, and then intracellular receptors. When we're getting into talking about the location of these, obviously the nuclear receptors are going to be located within the cell itself, so the drug has to get into the cell, down to the side of the nucleus, versus the cell surface receptors are obviously on the cell surface, right? So just briefly, getting to the ion linked channels, these are basically things that when bound, when activated, they will then open or close these ion linked channels, right? And the ions can be anything. It can be sodium, it can be chloride, it can be really anything. There's a lot of neurotransmitters that will do this. So for instance, like glutamate or GABA are really powerful within the CNS to cause changes, can either stop or cause seizures in some cases. And so just know that when they're activated, these will open up and allow ions to flow. This is generally along its concentration gradient. So this is a passive sort of process here. And you can hyperpolarize cells, you can excite them, all kinds of things can happen when bound by that ligand. And you can actually, depending on the tissue, you'll find that the subunits here will change out, and that way you can find that, say for instance, you have an acetylcholine receptor acting one way in this tissue, but acts a different way in this other tissue. And that's because these subunits have actually been modified depending on the tissue type you're dealing with, right? And we're not going to get super into the weeds on talking about different subunits, but this is just so you know why different drugs, or why the same drug may work differently in different tissues, is because of this sort of thing. And to give an example of that, here's some nicotinic receptors. You can see here, depending on where they're located at, they have different subtypes of receptors, and they will do different things. So for instance, this one will increase permeability to sodium and potassium, whereas in the CNS receptors here, it's increasing permeability to calcium. Those are the subunits that are changing depending on the tissue you're in, causing that change. So, and again, we have lots of drugs that can do this. So for instance, like nicotine, that's how we get nicotinic receptors, right? So when you smoke a cigarette with nicotine in it, this is what's activating those receptors to cause its various effects. It's calming effects, it's increasing blood pressure, all the different things. Sometimes we can have drugs that block ion channels. So for instance, calcium channel blocking compounds can help to lower blood pressure, for instance. We'll get into some more examples when we get into the secondary messengers next week, but these are things I just want you to start thinking about, the different types of receptors that may be targets for these various drugs. I think I'm not going to ask you specific examples on the test necessarily. I'm going to give you more kind of broad conceptual sort of questions. Next up, we have the G protein coupled receptors. These are a little more complicated, but they are ubiquitous in the body. They are everywhere, and basically they have the same structure here. They have these same 7 transmembrane sort of protein strands, and then they will have they interact with G proteins within the cell itself. And so there's over 1,000 of them that are responsible, and this is just in mice, just for smell alone. So there is a ton of different types out there, and again, we won't get into the weeds in terms of the different subtypes, but just know that they can be affected on by neurotransmitters and hormones, and even amino acids can do this in some cases. And about half the drugs we use work through the G protein linked receptors. So they're very, very common. You're going to see them used all the time. And so basically what happens is, say for instance you have an inactive G receptor protein here, and then here's your G proteins. Basically the ligand comes along, the drug comes along, binds this, and you'll notice here this is an active process because it utilizes a phosphate group to get GTP. Once this happens, then you'll have the activated G protein, and then we'll go and cause whatever downstream effect it is, whether it's to cause the cardiac cell to beat more strongly or to beat faster, whether it be on the vascular smooth muscle to relax, whatever the case may be. This is the component here that is causing those downstream cellular changes to occur. And then of course the process will reset itself to where once that phosphate group comes off, it can then go back to resting in its inactive phase, and then it's reset again to allow for another drug molecule to come and cause the same thing to happen, right? So you can see that it's important that we get back to the baseline level such that it can then be activated a second time. You don't want these to activate once and then be positive forever. They need to go back to baseline. And just to give you some examples of these different ones we have available to us, again, don't memorize these. I just want to show you the ubiquity of them. They're everywhere. They're used for all kinds of different things, like opioid receptors, used for olfactory purposes, used for photons in the eyes. They're everywhere. So very, very common. You see it pop up, those G proteins, that's what we're talking about. Next, we have some enzyme-linked receptors. These are typically more related to like cell growth and tissue differentiation and things like that. They're fairly slow-acting as compared to like your ion channels or your G-protein coupled receptors there. You normally will see this with like insulin receptors, and you'll see this with things like platelets and even like triggering cell replication. This is a big target for a lot of new cancer drugs that we have coming out now. There are lots of types, but this is the main one I'll focus on, or the most common one that comes up with drugs is tyrosine kinases. Basically, you have these two enzymes here, or two proteins, I should say, when they have two drug molecules come in and bind to them, they'll then dimerize and they get phosphorylated. That's what like kinase means, is they get phosphorylated, and then from there they activate proteins and you get whatever cellular response it is. So in the case, I think I have a picture here. No, I think I have it in the next lecture set. But in the case here, if say you have insulin come and bind to the tyrosine kinase, it will then cause more glucose transporters to come to the cell surface to suck up glucose out of the blood, right? That's what that would do. Or you could have some that would respond to certain hormones that will cause the tissue to start to replicate, cause cells to start to divide. And that can lead to cancer, right? So if I could block that, that could be something that could be beneficial. So you're going to see more drugs using those in the future, for sure, as they become more available. And then finally, with the intracellular receptors, this is the main one where you want to think about steroids and other hormones. They are typically things that can get into the cell on their own. So they will then come into the cell, they can pass that lipid bilayer no problem, and they get down into the nucleus and cause changes in gene transcription, protein formation, all that kind of thing. So for instance, if you have cortisol floating around, and then can interact with the liver to cause glycogenolysis and gluconeogenesis, for instance. All those sorts of things can happen through this regulation on the DNA itself. These are also typically slower acting, but they are very powerful in terms of their effects, right? So like testosterone, estradiol, I mean, that can have huge effects in terms of a developing body for sure. Slow but powerful. That's kind of the takeaway from those nuclear sort of receptors there. And so here's kind of the four of them put together, so you can kind of see, compare and contrast how all of these are going to be working here. So again, don't get too hung up on the actual examples that I mentioned, but we'll talk more specifically about those in upcoming lectures and also when we get into Pharm 1 and 2. Sorry that last bit was a little quick, but I always try to be respectful of your time and like to finish on time. And you can always go back and slow me down if you like. Any questions that I can answer for you? I'm going to check the sticky board here and see. Guess I lost a few people. I've got 40 left here. So no question on the sticky board. Any questions in the chat? I know it's a lot, but this is laying the groundwork for all of the other stuff we're going to talk about in the future. So it may seem like, why are we learning this stuff? It'll become more important, because if you don't understand the basics here, you're going to be losing. You just won't understand the fundamentals when you actually get into the drugs itself. Yeah, so Kyle said there's a sticky board. Yeah, absolutely. Maybe I should repeat that for people that might have joined a little bit later. If you go to the... Or are we the sticky board? No, you're not. I don't know how. I can't speak to your stickiness necessarily, but if you were to go to the modules section on Canvas, there's a link here for Pharmacodynamics sticky board. You can click that, and then you can post anonymous sticky notes here. So you can say that and just say test, and then you can post it. And I'll typically only check this during class, but it's a way that people can ask questions anonymously if they like. So. Actually, I had my 4-year-old the other day. She came up and she said, "Oh, my hands are sticky." And I said, "Okay, well, I guess 4-year-olds get sticky hands all the time." And then later on, I found an open thing of a glue stick. Glue stick was on the couch. And I said, "Is this what made your hands sticky?" She said, "Mm-hmm." And I was like, "Oh, boy." So that was fun. Cassette asked, for things such as protein receptors, what are some questions we should expect? I would expect you to know the different types of receptors we talked about. So for instance, if I say, a ligand bind it and causes calcium to flow in, it's an ion linked receptor, ion channel linked receptor. Or if I mention which one of these can cause, which one of these will dimerize and get phosphorylated, cause a downstream cell receptor or downstream cellular effect. That would be the tyrosine kinase receptors, right? And glue stick, unfortunately, she does not eat that. My other child is the one that likes to eat things. My 2-year-old, that was our fun quarantine event, where she actually ate a bobby pin, and we had to take her into. Fortunately, she passed it on her own, but that was not a fun time. Maybe I'll show you those X-rays later. Let's see. You have no questions on here, and if nothing else, you guys are free to go. I don't know when our next time meeting is, but yeah, OGs was right. It's not a fun time. Actually, I'm going to look on the site here, and I can see when our next lecture is. Yeah, thank you for joining me. I appreciate so many of you being here. Yeah, Tuesday, July 7th, so that'll be our next time, so it'll be a little bit of time. But enjoy your 4th of July. Please stay safe. Follow the guidelines, please, for the love of all things out there. Stay 6 feet away from people. Please wear your mask. That's the only way we're going to get through this. Glad you liked it, Richard. Thank you. And I will see you all on July 7th.